Whiplash injuries are common problems which GPs often manage in tandem with an osteopath. There are a few contraindications to osteopathy, for example nerve compression or vertebral pathology. But given these provisos, if you have a good, careful osteopath locally, then together you have greater potential to achieve success for the patient. Emanuel Sammut is an osteopath in Molesey, and we've met him before on Video Horizons. In our next feature, he explains his approach to whiplash and tells us exactly when and why a referral might be helpful for the patient. Every GP knows that even the most apparently minor whiplash can cause major problems and that they can go on for some time.
Now just let your head rest to one side. Just very gently push your head towards my left hand, just turn it, that's fine, and relax. Let the shoulder relax, good. A little bit more, push to the right, and relax, good. Let it go, a little bit more, that's fine. Push again.
Charlotte, you've had a couple of injuries, haven't you, to your cervical spine? Can you tell me about them?
Yes, I've had 2 car crashes. The first was a head-on collision in 1989, where I was driving along and someone was driving in my lane directly in front of me, and we had a head-on collision. And then 2 years later, I had another collision, but from the rear.
So in the first injury, your head went forward and then back, and in the second, it went back and then forward.
Yes.
Of course, it's when it comes forward that the damage is done, isn't it?
That's right.
Which of those injuries do you think did most damage?
Definitely the first one in 89.
And what did your GP suggest?
Well, he referred me for physio initially, which sorted it out temporarily, but it never really permanently relieved the problem. So eventually he referred me to the osteopath, since when generally I am much, much better.
That's good. Just let yourself go nice and floppy. Is that uncomfortable?
No.
There. Just a little bit of lack of movement. So we're just going to put a little bit of movement through there. Just bring your head up. Good. There you are. Nice little pop. One more. Let yourself relax. Let your head drop. Good. Well done.
Emanuel, GPs see whiplash injuries coming from a variety of sources. They come through casualty, some are self-referred, they may be mild or they may be severe. From your point of view, how important is it that you get to see them quickly?
Well, what is even more important, rather than get to see them quickly, is that you as a GP manage them in terms of giving them advice as to what to do. Now, supporting the neck is very important. That's not always necessarily a soft collar. A simple thing would be to get a woolen scarf, iron it, get it nice and warm, and just ask them to wrap it around the neck to give the support and the warmth. Prescribe some analgesics, some non-steroidal anti-inflammatories, and perhaps rest until they can get an appointment to see us. Usually most osteopaths will see a patient in an emergency on the same day. So the sooner they come to us, the better, but on the other hand, they should be as comfortable as possible. So it gives us an insight straight away as to what has happened with that particular whiplash.
Are there any danger signs that we should be aware of?
The obvious danger ones are paresthesia, any associated symptoms in the arms, or any symptoms of nausea or visual disturbances, anything other than just aches and pains or limitation of movement. Often the limitation of movement is immediate because of the shock, or sometimes the actual limitation or fixation of the neck actually happens about 48 hours later, so they're not always aware of symptoms straight away.
What would you say is the place for an X-ray?
When there are associated symptoms, just in case there is some nerve root involvement at the cervical spine level. So if the patient comes in and they're anxious about their neck pain, their neck stiffness, and then you suggest are there any symptoms in the hand and they're aware of loss of sensation or pins and needles in the hand, then we ought to really investigate the nature of the nerve root involvement.
What is it about a whiplash that causes such long-term problems? Perhaps you could demonstrate on the spine.
Because of the fast acceleration of the skull and then the deceleration of the skull, there's a massive insult, a massive strain to the ligamentous structure in the neck. Sometimes this is reflected also in the spinal cord being whipped out and whipped down again, so there's quite a strain on the meningeal cover, which is why sometimes patients get this feeling of electric shock feeling all the way down the legs, which passes after a few minutes. They just mention it if you talk to them. But as a result of the ligamentous injury, there's a lot of overlying spasm in the posterior structures as well as the anterior cervical muscles, which is why they often present with a fixation, a flexion fixation, where the head is held in one position. We've got to differentiate whether the pain is coming, if they're coming in with pains in the arms, whether it's coming from actual nerve root irritation, or often because of the impact on the steering wheel, they may have pain translated or transferred up the arm, so they may actually just have an arm injury as opposed to necessarily a neurological injury. Painful?
No, it's fine.
What about
Yes.
that? It is. Okay, so you're quite happy there,
Yes.
but you don't like it there.
No.
Okay. Is that
Can we
fine?
turn now to Charlotte's case, and could you tell us how she presented?
Yeah, the interesting feature about Charlotte is that she had her major whiplash in 1989, then she had a consequent one in 1992. Now, it's interesting with her, although she's a fit, young, active person, she's still getting symptoms from her whiplash. Now, the initial pain was in the cervical area, which was radiating down into the arms, but she had quite a limitation of movement, even though she's a swimming instructor and is in the water all the time. So with Charlotte's case, it's the long-term effect of a whiplash that are interesting to see.
How does an osteopath assess the cervical spine?
Two main ways. The initial way is active, i.e. what the patient can do. Right, Charlotte, I'm just going to watch you do some movements just to see what's happening to your neck. So if you can just drop your head forwards as far as it's comfortable. Is there any pain?
No.
No, that's good. Just slowly tip it backwards. Nice and slowly. Any pain there?
No.
Is it pulling at all?
No.
Is it sending pain down the arms or anything? No?
No.
Good. How far can they move? We go through standard ranges such as flexion, extension, rotation to either side, and then lateral flexion. We then try and simulate the movement on a passive way. That gives us an indication of what actually happens to the cervical spine when the muscles themselves aren't being active. So we usually have the patient lying down and we just move the head round to the sides, up and down, to compare the active movements with the passive range. And then in a case whereby there have been symptoms of paresthesia in the hand, or even if there haven't, we would do a simple neurological testing to test the reflex, test the muscle power, test the sensation of the hands and the arms to make sure there's no neurological damage. Can you just squeeze your thumb and your forefinger? Fine. That's good. The next one. That's fine. And again. Good. And again. Good. Okay, just clench your fist and just pull it in against me. Good. Push it out, outwards. That's fine. Now straighten your elbow against me. Good. And just bend it. That's fine. No pain?
That's fine.
Okay. Just push your arm into me. Push, push, push. Good. And away, the other way. That's fine. Any movements of the arm hurting you there?
And what about management? How are you going to manage a case of whiplash injury?
Now, again, they're all variable according to the severity, according to the underlying condition of their spine. So, for instance, an elderly patient that has underlying arthritic changes in the spine will have a more long-term approach, because we then look into a situation whereby the whiplash has upset the underlying degenerative changes. That'll be very variable to a young person having a whiplash, whereby it is just the ligamentous and muscular changes we're looking at. So sometimes a whiplash will spill over into upsetting underlying condition. So as you get better, you have nice puffy floats at the end of the arms, okay? So nice and slowly let the floats do the work for you.
So we're going to do 5 to the right, 5 to the left. Okay, so pull down to the side.
Keep looking ahead so that your neck is always straight, so you don't put a strain on the neck.
You're a bit unusual, though, in your management of Charlotte, in that you used hydrotherapy to try and help her. Why did you do that?
Well, being a swimming instructor, she's very comfortable in the water, and I found that in the initial stages, because of her experience of pain in the neck and having had treatment in the past from other types of practitioners, she was reluctant to let go, she was reluctant to relax her neck. So the easiest way would be to float her in the water and then manipulate the neck and the head and the shoulders when she's off weight bearing, so that she's actually more relaxed. It gave me a better access to the tissues as opposed to doing it on a plinth or a treatment table.
I have met doctors in my travels who think that manipulating the cervical spine will be a good way to get into manipulation. What's your reaction to that?
Well, I've met the same doctors probably, and I would advise them quite strongly not to. The neck is the most fragile area in the body to manipulate. As I'm sure you're aware, there are lots of plumbing and electrics in there. We've got our blood vessels, we've got our neurological structures, And you may achieve a pop, which is always the bonus point of manipulation, but you may also traumatize tissues. You may disturb and create an embolism in a vertebral artery. You may actually tear a nerve root from the attachment in the spine.
So the message is clear. We shouldn't get involved when we don't need to. We should consider sending our patients that require such skills to a registered osteopath. But that brings us to one crucial point: the medico-legal situation which arises when we do refer a patient. From your point of view, what are the implications?
What we must clarify is that we're talking about registered osteopath and not just an osteopath. Now, every registered osteopath can be identified by having the letters MRO after their name, which means they're a member of the Register of Osteopaths, which is the General Council and Register of Osteopaths. Now, every practicing registered osteopath will have insurance to cover them in the event of any law case. So we are independent practitioners, which we will stand and fall by our actions.
Well, after watching that, we hope you'll recognise that osteopaths have much to contribute in the management of whiplash. If we can work together, then the care of patients can only be enhanced.
After a certain amount of treatment, I begin to feel hope. The first time I've felt hope in 8 years, despite non-steroidal, anti-inflammatories, painkillers, etc. My quality of life has improved, my energy is improving.